use a 24 by 30, okay, landscape. It's the same orientation or the same imaging plate you would use for your shoulder, right? Because shoulder girdle, we need the full thing here. So full clavicles. Actually, is it 24 by 30 or is it 18 by 24?
24 by 30.
Okay, good.
Depending on patient.
Yeah, but is the norm 18 by 24 or 24 by 30? I think it's 24 by 30.
It is.
Okay, sweet, good. Awesome. So for the older rooms that don't have PVL, what you may want to do is you may want to pre-collimate your imaging plate, okay, in terms of, okay, how much light do I have to play with? This is going to come really handy when you do your AP shoulder and you need that full scapula, and you want to take advantage of the full 24 centimeters up and down, is that you want to just kind of pre-cone to your plate, so you know, okay, I can't go any bigger than this, but I can definitely go smaller, okay? So we're just going to do this example just for argument's sake. We don't really have to, but I think that's good to kind of alliterate. Okay, so we'll do the AP first, and we'll do the axial second. So AP clavicle is pretty straightforward. We're going to center right on the clavicle. We need the full clavicle, so what that means is you need the SC joint to AC joint, right? So we don't need all that soft tissue anymore. We don't need the humerus, all that other stuff, right? So we want to be halfway through your sternal notch just to make sure you do have that full SC joints, right? Past it to make sure you have that medial clavicle. And then for your AC joint, we already know where to palpate it, right? So we can palpate it and just go laterally beyond that, right? But we just don't want to see soft tissue, I guess is the big thing. If we see that you have light going past your shoulder soft tissue, we know that you haven't made the effort or know your anatomy in order to cone down to the AC joints, okay? So we're gonna get right side again?
Yes.
Okay, so just back up against the board, please. And then we're going to position the patients, right? So let's just back up, standing straight up, okay? It's easy as that. So now what we want to do is we want to turn on the light, and just because we've pre-coned, we know that this is our lateral margins. We're just going to kind of eyeball it so that we have equidistant light between mid-sternal notch and AC joint. So about here to here. So I'm pretty happy here. So then what you're going to do then is, at this point, you can cone in a little bit side to side. And once again, I'm just going to show where the sternal notch is. Sternal notch is right here. AC joint is about right here, right? So we're past the AC joint, and then now we can work on the height and collimation. So the thing with the clavicle is that it's one of these funny bones that kind of does like a little wave. So it's going to start off lower here, and then it's going to kind of curve up here. So it kind of goes low and then curves up. So in order to get the full clavicle, you need to make sure that you have the top and obviously the bottom. So don't cone in really tight, thinking that the clavicle is just one straight bone. It does have a curve in it. So when you're coning, you just want to make sure that you don't cut off the top right here, right? So that make sure that you have light above the shoulder there, and you want to make sure that you haven't clipped the bottom here. So we're going to center up a little bit higher, go right here, and then this is kind of where you would place your marker there. Okay, and then I'm just going to move the board up from behind you there. Okay, so just a quick double check here. Sternal notch, AC joint, top of the clavicle is here, bottom of the clavicle is here. So then we just want to make sure that we haven't cut it off, right? Starting down lower, curving up to the top here. So this is your AP. It's fairly simple. In terms of the breathing instructions, you want to do this on expiration. Okay, so that means you're going to tell the patient to breathe in, breathe out, hold your breath, okay? That is going to be for decreasing subject contrast. I don't know if that's been explained to you in terms of positioning or anything, but in quick terms, subject contrast or decreasing subject contrast and how that helps us is that when we do this on full expiration, we're not having a lot of black lung in behind the bone. So then if we do this in full expiration, we're going to fill those lungs up with horrible, horrible air, and then we're going to have white bone right in front of it. So the contrast is not really good. That's called high contrast, right? Because we have white bone, black air. So if we do this on full expiration, how that works is that now you have taken the air out of the lungs. So now you are kind of bridging that gap between being super white and super black, and then we're kind of decreasing that contrast so we can see the bony trabeculations, bony detail, and things like that. So that's going to be all done on expiration. Whereas when we do the axial, we want that on full inspiration, because inspiration will help lift the clavicles up even more along with that angle that we're going to use, okay?
Do you use a boomerang for this one or not?
You don't really have to. You can if you want. It's kind of like the AP shoulder, well, all the other shoulder views. If you have a thin patient that doesn't have a lot of soft tissue and you worry about burning out that AC joints, then yeah, you can definitely put a boomerang. DR, you don't need any boomerangs anymore, but if you want to, there's nothing wrong with doing that, for sure. Okay, so now axial clavicle, same positioning, okay? So patients are gonna be standing straight up.
Use your flashlight.
Sorry. Yes, I will. Thank you. Patient's gonna be standing straight up. We're just gonna change tube angle. We're gonna change the centering point just to kind of account for that. First, I just want to go over how to determine the angles. So can anyone tell me what the angle is for your clavicle?
For axial,
Yeah.
10 to 30, or 15
Yeah.
to 30?
So it's 10 to 30, is that what you said?
Yeah, 15
15
to 30.
Yeah, 15 to 30, exactly. So how do you determine what to use? Do you use 15, do you use 30, right? It's all based on body habitus. So a thicker patient, so someone who's deeper anterior to posterior will need less angle. The person who's fairly thin, let's just say for myself who's not very deep A to P, you need more. So just to, I need someone to hold this up actually. Just on that, yeah. Thank you.
Your model.
So you're gonna be the beam. So this is the X-ray beam.
Be the
Right?
beam.
Be the beam. Be the beam. So you're actually gonna hold it. Let's
Sorry.
Does this work with the camera?
Yeah.
Okay, cool. Okay, so we're gonna pretend this is the clavicle. Okay, so I'm gonna hold this right here. So at 0 degrees, actually no, let's switch. I think you'll be a better anguliner holder. Okay, so actually, you know what? I'm gonna do this a different way. I'm really confusing myself. Okay, we're not gonna use this. We're gonna get the patient to actually stand aside, and then, well, Tasia, you can just come and be my patient, or be my person. I'm getting really confused. Okay, you know what? Okay, you don't have to do anything. Sorry. Okay.
What just happened?
No, you're good. I changed my mind about things. Okay, so what I'd like you to do, sorry, is I want you to just hold your fingers like this, just in front of the board somewhere. So just like in this fashion, sorry.
But this way?
Yeah, cool. Okay, so let's pretend that this is your clavicle and this is the spot that we need to clear off, okay? So these are your lung APCs, right? Because the whole point is we're trying to get the clavicles over the APCs, right? So just imagine these are the APCs and this is the clavicle, okay? Because we're hitting the clavicle first. So we're gonna pretend that this is a large patient. So that depth is, the distance is gonna be greater than, let's just say like this, which is gonna be a small person. Perfect, okay. So we're gonna go to the big patient. This is the beam. So if I use a 0 degree, I'm just gonna get my gauge here. So if I use 0 degree, we're expecting the clavicle to be superimposed on the APCs. So now we're just gonna apply a really small tube angle. So something like that. So I barely move my phone, and you can see now how this finger, where your clavicle is now unsuperimpose from the lung bases, APCs. Is that okay? Mm-hmm. So now what I want you to do is I want you to bring your fingers nice and close, something like that. So this is the thin patient. Structures are still the same, but this is the thin patient. So once again, I'm gonna have a 0 degree, but now I'm gonna have to move my phone quite a bit to get that separation, right? So instead of just moving it like that, I'm gonna have to move it quite a bit now to get it off, okay? So that's what we mean by more tube angle for that thinner patient, and then when a patient's a lot bigger, then I will need to move my phone like this, and then now we're on, okay? So that's just a kind of a nice visual to have, just to understand that concept, because we don't want you just throwing 15 degrees, 30 degrees without knowing why. So, okay, now we can actually start with the positioning. So once again, back up against the board. We're gonna throw, let's just throw a 15 degree angle for you. So we're gonna use 15. So we're gonna set 105. Oh yeah, no, sorry, I meant to throw it the other way. Sorry. I was trying to compliment you and I totally messed that up. Okay, so 30, because your patient's nice and thin. So,
Be careful.
I totally screwed that up. Like,
Walking a fine line there, right?
I was not meaning that. You know where I was going with that. Okay, I'm gonna focus to. Okay. So with the steeper angle, we're gonna have to really drop that tube down. So we want to be 1 inch below that clavicle. So clavicle, mid clavicle here, 1 inch below it. Okay, that's just to help project it up. And then we're just gonna change our collimation accordingly. You can pretty much leave it the same way that you had it for your AP. Okay, so once again, just making sure you clear the most superior part of the clavicle, which is gonna be your AC joint, and just make sure you haven't clipped the bottom. Okay. And then this is kind of one of the more important parts to note is that we still want to shoot mid AP. So most of you will kind of do this. Let's move the board up behind me, sorry about that. Okay. And be like, okay, we're detented, we're good to go. But when you pull out this here, we're actually off by a good inch here. It's just because of the distance between the front of the bucky and the actual imaging plate here, right? That 2-inch difference will project a little bit farther up, okay? So what we want is we actually want to raise this up a little bit more so that we are mid-imaging plate, not mid-bucky. So if I turn that light on again, we're well below that light or that line there, but we're right mid-IP. So this is what we're looking for here, okay? To be mid-IP. So I'm gonna close that off. If we're still happy with the positioning, then we can go ahead and take that picture. And then once again, the only difference in terms of breathing instructions is this is just on full inspiration. So take a big breath in, hold your breath, beep, you can relax and breathe, and then that's done there. Okay? You can put a lead marker in the primary beam to signify that you did use an angle. So you can use a up arrow to signify cephalid. If you have lead numbers, you can put lead numbers down, but if not, just post annotate, right? But we always will try and get that in. Okay, cool. Good? Okay. Yeah, sorry about that angle.
Yeah.
I was totally wanting to be